We'll be preparing clients for moving into PHP and IOP and eventually outpatient, where they do more of that advanced work. So as you get into these higher kind of up the pyramid, or drop to lower levels of care, then the therapeutic work starts to get deeper. It starts to get more insight oriented, more process oriented. So when I develop treatment schedules and I look at the interventions that I'm going to be using at a level of care, my kind of the philosophical underpinnings of that are coming from that kind of hierarchy pyramid of where are we at, what's appropriate for them. The schedule at Malibu and the way we set things up in Malibu, it's going to be a much heavier emphasis and focus on group programming and scaling back a little bit, not a whole lot, but scaling back a little bit on the individual, on that level of need and those foundational needs that clients at this level are needing a lot of skills, a lot of psychoeducation, a lot of skill building. They're needing concrete things that they can take and use in the next level of care. And so those are going to come a lot from the group experiences. I lean really heavily into evidence-based practices, and there are 3 main EBTs that I use. One of them is IMR. IMR may be new to you guys. Not a whole lot of people have heard about it, but it is a SAMHSA evidence-based model. It's called Illness Management and Recovery. It's designed for a very acute psychiatric population. So IMR is perfect for your acutely manic individual, somebody who's having a psychotic break, somebody who's struggling with, it could be hallucinations, delusions, severe depression, severe anxiety. That would be kind of the appropriate group for IMR. So I build that into these schedules knowing that, we're always going to have probably at least a couple, if not more, clients who are struggling with these acute symptoms. I also lean into DBT and CBT. I break it out into skill groups. So you'll notice that I do emotional awareness and resilience, cognitive restructuring, healthy boundaries and self-care, coping skills to stress tolerance, healthy communication, and interpersonal effectiveness. Those are all skills and components of CBT and DBT. We will have a process component to the schedule. We'll also focus on trauma, although trauma interventions likely will not go deep into in a residential setting, but we will be trauma informed. And what that means is that we're going to be recognizing in all of our clients that their trauma exists. We'll be setting up kind of how we communicate, how we interact, how we intervene, how we set up our environment to be sensitive to trauma. And then we'll do a lot of education about trauma, kind of setting the stage, also helping to develop those coping skills and resourcing so that when clients are stepping down to the next level of care, to PHP and IOP, they're ready and primed to do more of that deeper trauma treatment work, whether it be EMDR, somatic experiencing, or hypnotherapy, whatever that might be.